Good afternoon, everyone. Myself, Dr. Jasmeet. Today, I'll be presenting a case of bullous central serous chorioretinopathy with spontaneous retinal pigment epithelial rip. A 34-year-old male presented to our department with the chief complaints of sudden painless loss of vision in the left eye since 1 month. There was no history of trauma to the eye. There was no history of any steroid intake. He was not suffering from any systemic illness, and there was no significant past family history. On ocular examination, the visual acuity in the right eye was 6/6 and in the left eye it was 6/36 with no improvement on correction. The slit lamp examination of the anterior segment in both the eyes was unremarkable. The IOP was normal and gonioscopic examination has grade 4 in Schafer's grading. This is a fundus photograph of the right eye showing CDR of around 0.3. Vessels are normal. There are multiple RP changes at the posterior pole. This is a fundus photograph of the left eye. The CDR ratio is around 0.4. There is an inferior bullous retinal detachment, RP atrophy temporal to the fovea, and neurosensory detachment at the fovea. This is an autofluorescent picture. In the right eye, we can see multiple hyperfluorescent areas. In the left eye, we can see a hypofluorescent area, which is corresponding to the RP tear, surrounded by an area of hyperfluorescence, which is due to retracted RP. This is an OCT image of the right eye. There are multiple neurosensory detachments with shallow PED. This is an OCT image of the left eye. There is a shallow subretinal fluid at the macula, PED temporal to the fovea with RP rip at the dome of the PED and rolled out edges of the RPE. This is an FFA image of the right eye. There are multiple pinpoint areas of hyperfluorescence which increase in intensity in the late phase. This is an FFA image of the left eye. There is a well-circumcised area of hyperfluorescence in the early phase, corresponding with the loss of RP, which increase in intensity in the late phase, with narrow portion of blocked fluorescein on the inferior margins and consistent with retracted RP. So the differential diagnosis could be Vogts-Koyanagi-Harada, sympathetic ophthalmitis, which is ruled out because there is no history of trauma, posterior scleritis, ruled out again because there is no history of any pain or tenderness, choroidal tumor, the B scan was normal, and lastly UV diffusion syndrome. So the provisional diagnosis based on the multimodal imaging is that the patient is suffering from bilateral central serous chorioretinopathy with left eye inferior bullous RD with RP rip. Focal laser was done to discrete the leakage areas in both the eyes. Spontaneous retinal pigment epithelial rip has been reported more commonly in association with neovascular macular degeneration, post-trauma with intravitreal anti-VEGF injections and CSCR. RP rip usually occurs at the junction of detached and flat pigment epithelium. Tears in the RP was first described by Hoskin et al. Reports of RP defects in association with CSCR are rare. Steroid usage is an exacerbating factor. Our patient developed the spontaneous RP rip with CSCR without any history of steroid use. Another interesting fact is that the RP rip was seen at the dome of the RP detachment and not at the edge of the PD as seen in AMD. So I conclude here by saying that the bullous retinal detachment is a rare manifestation of chronic CSCR. RP tears may rarely occur in CSCR, particularly when the neurosensory detachment is associated with underlying PED. Due to its peculiar clinical findings, it can present as a diagnostic dilemma and lead to inappropriate management. Treatment of bullous CSCR is still a matter of controversy, and failure to differentiate bullous CSCR from other diseases may result in inappropriate uses of corticosteroids, worsening the clinical picture and leading to poor visual outcome. Further studies are mandatory to address these issues for improving patients' care. These are my references.